presentation, please. So Emily, we'll probably, I give you 90 minutes, so whatever that works.
More than enough.
Yeah, so.
Probably closer to an hour-ish.
And then the questions, and then I have a feeling you're going to get a lot of them, so, yeah. So. Okay, if you can make your way on in, we're going to get started here. So one of the things you will notice is we have a pretty packed house here. I mean, this is great, and it's wonderful to see such interest here today. There are empty seats up front, though. If people are willing in the rows to move in, I'd appreciate it. Obviously, you don't have to. But it would be nice, particularly for people, if you're looking for a seat, there are plenty available here. A couple other quick points. If you do want to purchase CEUs and you haven't done so, please see Taylor up at the front desk if you want to purchase vis-a-vis credit card. Otherwise, you can see me or any of my staff. We're all wearing University of Minnesota gear, I guess. And we'll take your check if you're willing to pay by check. And the last points, too, is please remember, fill out forms if you're interested in participating in one or two of our studies. The free remote activity monitoring study, where we provide you with the sensory technology for a year and a half. That's that documentation or permission form in your handouts. And then also, too, see the exhibit with Quinn Maroney and the facial recognition technology study as well. We're still looking for participants for that project, too. And again, I'm going to be hounding you about this throughout the day. So, yeah. So our next speaker here is Dr. Emily Olson. This is actually a great presentation now because it's going to dovetail really nicely with Dr. Peters' talk, particularly some of the last comments that were made related to, having the doula, having someone within a healthcare system that can help provide ongoing support, ongoing assistance across the various transitions that can occur throughout dementia. And that, in essence, is what Dr. Olson does at Fairview. She runs her own memory loss clinic. She's a geriatrician at Southdale, correct, Emily, in the Edina area. And she's going to basically talk about what are some of the main issues that come up in her memory loss clinic. And I think it's going to be a wealth of information, great resources and tools for you. So please help me welcome Dr. Olson.
All right, thank you, Joe, and thank you all for giving me the opportunity to speak to you today. I hope this is some helpful information. I have no financial disclosures. That's one of the things that we have to say at a lot of our physician-type talks. But so I am a primary care physician, as Joe mentioned. I practice with Fairview at the Edina location, and I'm trained in internal medicine and geriatrics. I did my geriatrics training at Hennepin County Medical Center under Dr. Larry Kersner, which I'm sure some of you here know. And so then I've been working at the Fairview Clinic for now almost 3 years. I do primarily primary care, but 2 afternoons a month I have the opportunity to focus just on memory care, which is really rewarding for me and something that I really enjoy doing. And so as Joe mentioned, the purpose of my talk really is to give a little overview of dementia, the diagnosis and some of the management that follows, including not just medication therapy, but some of the other non-medication therapy that even Judy alluded to in the previous talk, to understand how dementia impacts the other person's medical conditions themselves, and to understand how to navigate that medical system more effectively, because I understand that it is very challenging. There is a shortage of primary care as well as geriatricians. So basic definitions here, and I won't belabor this too long, but dementia by definition is an acquired decline in 2 or more cognitive domains that is sufficient enough to impact a person's daily life. So there are 5 main cognitive domains that are listed here: Memory is one of them, and often there's a lot of focus on memory loss when we talk about dementia. But the other areas of how our brain functions are noted here. Executive function, which is the way a person plans, makes decisions, controls their impulses. Paying attention is very important. Language, communication skills, and then something we call visual spatial processing, which is our sensory and motor functioning. So all those 5 groups are very important in what we call cognition, and for there to be a diagnosis of dementia, at least 2 of those have to be impaired. And it's also important to note that dementia is not a normal consequence of aging. I think a lot of people here understand that. There are some patients that live well, into 100 years old and they do not have dementia. But it is, of course, more common to have dementia in someone as they age versus someone who may be 20 or 30 years old. So this is a list of 10 early signs and symptoms that can occur in dementia. It's put out by the Alzheimer's Association. It's important to note that not all of these have to be present, and they're not diagnostic criteria, but they're just some important things to watch for. So the first is memory loss, that it disrupts the daily life. Challenges in planning or solving problems. Difficulty completing familiar tasks, both at home or at work. Confusion with time or place, trouble understanding visual images and spatial relationships, new problems with words in speaking or in writing, misplacing things and losing the ability to retrace their steps to find those misplaced things, decreased or poor judgment, withdrawal from work or social activities, and then changes in mood or personality. So the dementia diagnosis, that combination of both cognitive and functional impairment that both have to be present. How do we in the clinic come up with that diagnosis? Well, it requires multiple different pieces. We get history both from the patients that come to us in the clinic, but also very importantly their family members, friends, other loved ones. Because a person who has some concerns with their cognition might not always be able to give us an accurate history for many reasons. One, they just may have lost the ability to do so. They also oftentimes are fearful of losing some independence if they share too much information with us. Or they might not understand or what we call lack the insight into the changes in their cognition. As with any time you go to a physician, oftentimes there's also a physical exam, which is important. And then there are a variety of cognitive and functional assessment tools that can be done. One called the mini-cog, which actually is built into a lot of what's called the Medicare wellness exam that folks 65 and older will sometimes do, where there is a question where a patient has to answer or repeat 3 words, draw a clock, and then come back to those 3 words. Something called the MOCA, which I'll talk about a little bit more later. The MMSE, which is the mini mental status exam. SLUMS is another assessment tool. And then something that our occupational therapists help us a lot with is called the CPT, or the cognitive performance test, and I'll talk more about that in just a bit. And then oftentimes physicians will also order some lab work and potentially some imaging, such as a CAT scan or an MRI of the brain. And it's important, just as a side note to some of the clinical folks out there, that it's important to not make a diagnosis of dementia during what's called delirium, which is often seen when patients are ill, maybe in the hospital in unfamiliar situations, which is a short-lived, transient, reversible, fluctuating syndrome characterized by lack of attention. Dementia has to be a chronic and progressive thing, and not this short-lived delirium. So this is an interesting illustration where patients are asked to draw a clock, and you can see in the upper left what is considered a normal clock. Unfortunately, as there is progressively more cognitive impairment, you can see the changes in the clock as you go down to the right. And this one task in the clinic can really give a lot of information as to where a patient may be at in their cognitive impairment. The MOCA is a standardized cognitive assessment tool that I often complete in the clinic. It stands for the Montreal Cognitive Assessment. And you can see there are different sections. And while it looks like it might be somewhat easy because there's pictures of animals and numbers and letters, it actually is a quite challenging test. It's out of 30 points. And on the far left, you can see some of the headers that really go into some of those cognitive domains that I mentioned earlier on. So this test takes about 20 minutes to complete in the office. And during that 20 minutes, where by all means it doesn't give us all the information that we need, but it does give us a little window into the patient's cognitive abilities. So that is something that we can do in the office and then repeat it serially to track how the patient is doing. So then there's something called the ADLs or IADLs, which stands for the activities of daily living or the instrumental activities of daily living. And this is the function piece that I was mentioning. So activities of daily living are the things that people need to do every single day to take care of themselves. Think about it as the things you do when you get up in the morning to get yourself up and out the door. It's getting up, going to the bathroom, bathing, getting dressed, eating, and just basically getting up and walking around. Whereas as we from a little child grow up and go to school, we start learning more complex tasks, which are these IADLs, or the instrumental activities of daily living. So this is where people will learn how to manage their money, manage their medications, take care of their home, go shopping, complete employment, preparing meals. So looking at these activities, a patient with dementia or memory loss will start having more and more difficulty with the IADLs before they will start having more difficulty with their ADLs. The more complicated tasks will often be more challenging for those patients before the more basic tasks. And the occupational therapist, and I'll talk about this a little bit more too, will go through and do some testing basically for us on the instrumental activities of daily living to give us some information. So I gave you a general framework of dementia itself. That's the big category. I just want to take a moment and talk about the different subtypes of dementia. Alzheimer's disease is the most common type of dementia. It affects about 70% of patients with dementia. The second most common is vascular, and that is changes in cognition as a result of, for example, a stroke. A second, or another subtype is Lewy body dementia, and then closely related to that is Parkinson's-associated dementia. So the difference between these two is the time course into which the changes occur in that person's life. So a person with Parkinson's does not necessarily develop any cognitive impairment, but sometimes after they've had a diagnosis of Parkinson's for a number of years, they might start having difficulty with their cognition, and that would be a Parkinson's-associated dementia. On the other hand, patients who start to have changes in their thinking and memory, as well as changes in their movements. They might be getting more rigid or slow or tremor. If that all occurs within about a 1-year time period, that's what's considered Lewy body dementia. And a challenging aspect of Lewy body dementia is that these folks will oftentimes have some hallucinations, which may or may not be scary, but that is commonly seen. And then another subtype of dementia is called frontotemporal dementia. This is often seen in younger patients and is highly associated with some behavioral or personality changes. And other associations I have listed here, I won't go into detail about them. But what is interesting is that there can also be a combination of all of these subtypes, which makes it difficult clinically for us as providers and the patients themselves and their loved ones to take care of them, because you might have someone who's already starting to experience changes with Alzheimer's type dementia, and then they have a stroke on top of it, which makes it very challenging. So I'll take a brief moment to talk about something slightly different, which is called mild cognitive impairment. And this is something where there are changes in the cognition, but the function is still maintained. So these folks are able to go about their day-to-day life and function normally, but they are just starting to notice some changes in their thinking. There are two subtypes of it. One is related just to the memory piece, in which we call amnestic mild cognitive impairment. And then there's another subtype, which is non-amnestic, and that is more patients who have cognitive impairment changes, for example, in their visual processing skills or their impulse control. So the interesting thing with mild cognitive impairment is that there is a high likelihood with conversion rate to a diagnosis of dementia. On average, anywhere from 6 to 15% of those folks will have an annual conversion rate to dementia. But interestingly, some patients with a diagnosis of mild cognitive impairment will actually improve. There are no FDA-approved medications for mild cognitive impairment at this time, although sometimes clinically they are used. We encourage those patients to have healthy lifestyle habits, be as engaged socially, mentally, physically as possible, and we follow them closely in the clinic. And it's estimated that up to 20% of those aged 65 and older may have mild cognitive impairment. Now, just a brief note too, it is normal for everyone to have some mild memory changes as we age. And so it is normal to occasionally forget some words or to have difficulty with names, so not to fret. So some diagnostic difficulties. There is a gray zone in that progression from the mild cognitive impairment I just spoke about to dementia, which makes it difficult. And then the clinical overlap of dementia subtypes, as I mentioned earlier. Actually, we cannot officially diagnose the exact subtype of dementia without an autopsy, which of course doesn't help us in our day-to-day lives. But we can make a pretty good educated guess based on some of the clinical information I did give you. Versus, for example, the person that has already a diagnosis of Parkinson's and then they start developing cognitive changes. We think of Parkinson's associated, or the patients with hallucinations and movement disorder together would be a Lewy body dementia, etc. It can be very difficult to get the history from somebody other than the patient, which makes it difficult for us as healthcare providers, because maybe they don't have anybody in their lives that is there with them. They don't have any children or loved ones or friends or neighbors. They might be totally on their own. So that is, as you can understand, very difficult for us in the clinic, being able to get that information. Maybe they have loved ones, but they are far away, so they can't come into the clinic and help provide information. So that makes it challenging. And then again, patients themselves are very fearful of a loss of independence if they tell us too much information, or they just simply can't understand the changes that they're going through. And then while everyone here is very much aware and trying to learn more and more about dementia, there still is generally a lack of public awareness regarding differences between normal age-related memory changes and the dementia itself. So the pathway to coming up with this diagnosis. Of course, every person is unique, but there are some common themes that we see, and I have them listed here. A very common presentation to a primary care physician is that the patient and or the family will come to the clinic with concerns, oftentimes with short-term memory loss, repetition of the same thoughts or questions. There'll be potentially more difficulty with completing those daily tasks. We might see that hygiene is slipping. Maybe they're losing some weight. Maybe their home care is not as well kept up, or there's difficulties even in their job. Unfortunately, sometimes this comes to us because there's been a financial scam, that somebody has called and tricked a patient with something, and they've lost lots of money. Driving violations can sometimes be the first time that this is observed. Uncontrolled chronic disease. For example, if you have someone who has diabetes and for years has been under good control, and then you notice over the course of 1 to 2 years, things start changing and you wonder why that is. They might have some underlying cognitive impairment. Maybe there's a change in their personality or behavior with increased anxiety or depression, more isolation, pulling away from the activities that they used to enjoy to do. That's very common. They're not doing the hobbies anymore that they used to do, which in reality we want to get them more out and engaged in doing those things again because it's so good for their brain. As I mentioned earlier, the Medicare Wellness Exam will often have this mini cog with the 3 words clock and 3 words. Sometimes that's the first time that this presents. Lastly, a patient who goes into the hospital for an illness such as pneumonia, and they all of a sudden get very confused and disoriented, and you might then afterwards kind of dig a little deeper and realize that there's been some underlying cognitive impairment all along. So initially, oftentimes, patients will come to someone like me, their primary care provider. That person will start a basic workup, and then oftentimes the primary care provider might refer on to a subspecialist such as a neurologist, a geriatrician, a psychiatrist. Neuropsychologists are great. They're able to do some really high-level testing with some patients. If patients are already very advanced in their disease when they come to the doctor with this, they don't always need to go through all those routes. And then occupational therapists. So therapies. Unfortunately, there is no cure for dementia at this time. The researchers are working very hard on that. And also, sadly, there are no disease-modifying therapies that alter the underlying course of the disease. However, there are medications that we can use that actually do have some benefit that help with symptom control at times. So we don't want to discount them altogether. And the primary goal is to improve the quality of life of these folks and their family members and loved ones, and maximizing their function as much as possible without enduring significant side effects. Besides the medications, there are also non-medication therapies, and of course support for the caregivers like you, who we can't forget about. So there are 2 main classes of medications. The first is kind of a mouthful, acetylcholinesterase inhibitors. There are 3 drugs in that class. The most common that is used is donepezil, which brand name is Aricept. The others, Exelon and Razidine here. And then another class is this NMDA receptor antagonist, and that goes by the name memantine or Namenda. The first class is often the first type of drug that we try in earlier stage disease, and then potentially the memantine can get added to it. In 2014, there was an approval for this drug called Namzaric, which you may be seeing some advertisements for, and really that is a combination of the donepezil and the memantine together just in one pill. So the goal of medications, again, is trying to improve function without enduring significant side effects. And not every person needs to be started on a medication. It's recommended that all patients at least consider a trial with a medication therapy. And it's interesting, I have a good handful of patients that are not interested in medications at all. So it's important to have that discussion with the patients. And if patients do decide that they want to commit to a trial of a medication, we often try to go at least 3 months on that medication unless we need to stop it for side effects. About 10 to 25% of patients may show some modest global improvement. So unfortunately, you can see that's not a huge response, but it's something. And then there's a larger percentage of folks that may have a less rapid cognitive decline. So when I'm seeing patients and their family members back into the clinic, I try to see if either the patient themselves or their loved one has seen any kind of response, either good or bad, checking on their cognition, behaviors, personality, their mood. Are they more apt to go and do the hobbies that they used to do? And then if the folks either improve or stabilize, we continue the therapy. An important note is that these medications have been shown to potentially delay the worsening of symptoms for up to 6 to 12 months for about half of the patients, which is not a long time, I realize, but it is something, especially if you consider that it's 6 to 12 months longer in their own home or before having more and more help in the home, and that is a great benefit to patients and their families. And it's also important to know in the studies actually on donepezil, the average age was 73. So we have a lot of folks out there that we're treating that are much younger and much older than that. Side effects. This is an overwhelming slide, but I'll try to break it down for you. The medications in that first group, the acetylcholinesterase inhibitors like donepezil, do have some significant side effects. So the most common group of side effects are listed right above there, are gastrointestinal. So nausea, vomiting, diarrhea, stomach acid ulcers, poor appetite, and weight loss. That being said, a lot of patients tolerate them fine, but of course when I start this medication I bring that up. Urinary retention, and on the opposite side of that also incontinence can occur. Vivid dreams or difficulty sleeping, slow heart rate or what we call syncope, where a person passes out related to their slow heart rate, fatigue, muscle cramps, respiratory distress. But one little trick that I use in the clinic is that we can change the timing of the day of the medication to try to alleviate some of those side effects. So if a patient is having a lot of nightmares or difficulty sleeping and they're taking it at nighttime, I'll switch it to morning, and that oftentimes will help. Vice versa, if there's a lot of nausea and they're taking it in the morning, switching it to evening time can be beneficial. And it's important then when dose adjustments are made, we go very slowly, because that has also been proven to reduce the chance of side effects, giving at least a month in between any dose adjustment. Memantine is usually a little bit better tolerated. There are side effects: dizziness, headache, constipation, sleepiness, and interestingly, confusion is written on there, which I don't know how to kind of sort that out, but it's listed. And so that's the importance of monitoring therapy, obviously, in the clinic. And this medication can be prescribed either as twice a day, or there's an extended release formulation that's once a day. And there's a nice starting pack that can be prescribed that's really easy to advance the dose as it is started over the course of a month. So I talked a lot about when to start these medications, but when do we consider stopping the medications? Well, if any of those side effects that I just mentioned are very burdensome, of course, it's not worth putting someone through that, so we stop the medication. Or something that's called the prescribing cascade, which is where, for example, if a person has some nausea related to their medication and then all of a sudden they get started on an anti-nausea medication to combat the side effects of the first medication, we don't like to see that, because that just builds and builds and builds. And then we also stop medications when we're no longer seeing a benefit, and that's often in advanced stage disease. So, for example, if patients are already having difficulty remembering their loved ones, and they're maybe in a nursing home or on hospice care, any point in there we can pull the therapy back. But sometimes family members can see a decline in their cognition just briefly when we do stop a medication, so it's important to know that. Usually it's a very vague response that I get from families. For example, I had a husband say that when he stopped the medication for his wife, she just wasn't able to quite find the handles on a door or open the refrigerator like she used to. So something small like that, and then they were just able to modify and adapt and work through life that way. But it's important for me and other providers out there to educate the families if we do stop the medicines. So moving on to therapies that are not medication related, because this is very important as well. So it's very important in all stages of the disease process to try to encourage mental and physical activity. And this can be very important to try to encourage the hobbies that these folks used to enjoy, whether that's music or drawing or painting. Socialization itself is very important, so it doesn't have to be anything new or elaborate. Just getting folks out and talking with other people, if they like to do that, is helpful. Music therapy, pets, encouraging good nutrition, going for a walk, all these are very beneficial for the brain. And then there are some alternative therapies out there. These do not have any firm evidence yet to support their use. So things like coconut oil, I think some people are trying, and while there might not be any firm evidence, it's also probably not very harmful, so it's okay to at least try. And of course, researchers are working on more and more things. Vitamin E is, there's data on that, but it's sort of mixed at this point. And in later stages of the disease process, adult day programs are really beneficial. It gives the caregivers some form of respite because the person with dementia is now with some other folks. And that also in the adult day program keeps their brain stimulated, which is wonderful. And I've had family members come back to me and say that they notice a positive change in their loved one after that being involved in a day program for a while. And then another subject that I'll talk about briefly here and then more further on is redirection of some worrisome behaviors. And we talked about that earlier on, that behaviors is kind of a negative connotation, and so we're working on rephrasing that. But there are some things that are not favorable that some of these folks do, and we try, if all possible, to not use medications to treat that, but redirecting them in positive ways. And this is because patients with dementia, they can oftentimes react to unfamiliar places and things, and they might be stressed or anxious or worried. They don't know where they are, so they're scared. So trying to comfort these people is really important. So tips for redirection: travel with them to where they are in time. We heard a lot about this from Judy's talk. Speak slowly and calmly. Even if they don't understand the words that you may be using, especially in later stage disease, they may understand the tone that you're using. So validate that the person seems to be upset about something, and then reassure them that you want to help them in any way that you can. Try not to disagree, and do try to respect their thoughts. Move them to another room or a calmer environment if you can. So if you're at a family get-together and there's a lot of commotion in one room, and the patient or the person with dementia is feeling agitated, try to go into a calmer environment. Give them something easy to do that might be calming. And then if the caregiver themselves is the cause, and you can safely do so, try to step away from it a little bit. The environment is very important, and so consistency is often helpful. Daily schedules, surroundings, and care partners it's nice to be as consistent there, and avoid extremes like bright lights, loud sounds. Some people like to be social and be in crowds, others like to be more isolated and are introverted. So think back to who they are as people and try to accommodate them as best as you can, because again, everyone is different. And an interesting example of this is bathing. This is a very complex task. There's a lot of steps that we have to do in terms of bathing. You have to go into a slippery tub or shower, which is scary for people. Risk of falls. You might be with a care provider that maybe you do know, but maybe that person forgot who you are, and so they're scared. It's a privacy infringement. Temperature of the water. So when you think about the bathing aspect of someone with dementia, just keep in mind how many steps are there and how to just slow down and be cognizant of if you're the caregiver trying to help them through all those steps. And then One thing that can be helpful if a person is resisting bathing, part of it is they may have forgotten why that's even an important thing to do anymore. They've lacked the insight into why we need to stay clean and hygiene. And so, and while you as the care provider want to try to help with that, maybe it's not as important to do it every single day. You can kind of come up with ways about going around that. And also you can give them an option, well, do you want to bathe now or later on? So, yeah. And then something called sundowning. This is a phenomenon that usually occurs, as the title calls it, as the sun goes down. It's going into dusk and continuing throughout the night. And it's a period of time where there's more confusion than their baseline, more anxiety, agitation, potentially pacing. And think of it as the brain has been working on overdrive all day long, and it's simply just really tired. So going into a little bit more detail about sundowning, here are the contributing factors: fatigue, stress, new environments or routines, confusing nonverbal cues from those around them, low lighting, or if their sleep cycle gets way off. This can happen in hospital settings. So how to improve things? Scheduling important activities or outings earlier in the day. So if you have to make it to a social gathering or a doctor's appointment, etc., it's probably better to schedule that at 10 a.m. than it is 4 p.m. Avoid caffeine and alcohol if possible. Having a lighter dinner is probably easier than a heavier dinner, which might lead to some discomfort in the abdomen and more pacing. And then encouraging really easy and relaxing activities in the evening while maintaining the adequate lighting, so that's not a confusing thing for them. And then if they're pacing throughout the home, as long as they're safe, you can allow them to do that or to walk along with them and be a partner in that. And then talking with the primary care provider about potentially adjusting the times medications are administered. Sometimes that can help. And then trying to really think about any potential triggers as to the cause of the sundowning behavior. So caregiver support. I can't say this enough. This is some pretty scary statistics here that in 2016, those who took care of loved ones with dementia provided an estimated 18.2 billion hours of unpaid assistance, which was valued at $230 billion. And that doesn't even include the emotional and personal health impacts that caregiving, that's involved in caregiving. And up to 40% of caregivers have reported depression. So respite is very important. And there are numerous organizations, some of which are here today, but Alzheimer's Association, Act on Alzheimer's, and numerous others that are helpful resources. So I'm going to go into the different stages of dementia just briefly, because you may hear this terminology: early, moderate to severe, which is also called early, middle, or late, or mild, moderate, severe. They're the same, just a different wording for it. And just note that this is a general guideline, as signs and symptoms often overlap. So in the mild or early stage dementia, often folks are still living independently, or they may be with their spouse or other loved ones, but they have a notable change in their cognitive and functional abilities that's evident to themselves and their loved ones. It's important to really treat anxiety, depression, and grief surrounding their new diagnosis and pay attention to that. If someone drinks a lot of alcohol, it's helpful to start pulling that back, because it's going to be harder and harder to pull that away later in the disease process. Increased partnering is a good term to use. So partnering with others for safety should be encouraged. So having someone check in once in a while on their driving ability, do ride-alongs, check over the finances, help set up pill boxes. These folks often need reminders and cues, but still trying to balance letting those folks do as much as they can safely do. Checking into clinical trials, sometimes that's available really early on in the stage of disease. And then it's really important to have these hard discussions about future plans, putting together an advance directive, goals of their care, powers of attorney, all of these things. Moving on to the moderate or middle stage, this is where there's a loss of the ability to complete those instrumental activities of daily living, like the medications, the finances, the driving. And the progressive cognitive decline starts to affect other areas, such as not just the recent memory, like what you had for lunch today, but what school you went to in the past. Hygiene and self-care will start to go down, changes in sleep pattern, and potentially personality changes. Some folks might get more suspicious, have delusions, hallucinations, more aggression. And this is where transition to 24/7 supervision and care. And that doesn't, as we learned in the first talk, that doesn't necessarily mean moving somewhere. It can, but it's just having conversations about how is that person going to be watched out for. And then lastly, into severe or late stage disease, there's a progressive loss of the ability to complete now their ADL. So those things that they need to do to take care of themselves. They're bathing, they're dressing, they're actual physically eating. And these folks can be very vulnerable to infections such as pneumonia and pressure ulcers as they lose the ability to get up and walk. They're often bedbound, so they require a lot of care. And then they may potentially qualify for hospice, where we always talk about we never stop caring, we just stop trying to pursue a cure, and we focus more on quality of life and comfort care. And then I won't go into this a lot, but sometimes a question comes up about feeding tubes, and that is not recommended by multiple medical societies for dementia. Just because the feeding tube is a risk because patients can pull at it and that can cause problems. The thought in the past was that feeding tubes could help prevent what's called an aspiration pneumonia. But even if they're not eating, they can get their own saliva into their lungs and still be problematic. So we do not recommend feeding tubes. And then navigating the medical system, which I understand is definitely very challenging, work in progress, but working together as a team with the primary care provider, the specialists, and then the other care teams, nurses, social workers, etc. Consider clinical trials, as I mentioned, consider the medications. Early in the disease process, that partnering together on driving and finances. There are resources available for driving, such as if a person needs to have a driving assessment, the DMV, Adaptive Experts and Courage Center. The difference in those three is that DMV is the more financially viable option. And patients can go and request to take a test. Adaptive Experts and Courage Center, they're more costly. Adaptive Experts will come to the person's area of the community, and so that person can drive in familiar areas, whereas Courage Center is more at a testing site. And so an interesting thing, sometimes physicians feel that they need to report to the DMV in really challenging circumstances where there's been quite a decline in the cognition, and we just don't feel that it's safe for public health for those folks to be driving, and that's such a touchy subject because driving, there's so much independence involved there, and so these are very, very difficult conversations. But if patients are unwilling to give up their driving privileges, then sometimes we feel forced to report to the DMV. But also, you as community members can report to the DMV yourself if you have concerns about someone and their driving. And then looking for community resources. And being aware that if your loved one has dementia, that if they do need to go into the hospital for any kind of either elective procedure or they become ill, there's that risk of delirium I mentioned. So making sure the care team in the hospital is aware of the diagnosis of dementia. There are ways to try to mitigate that delirium by frequently reorienting the person, trying to be by a window if possible, keeping the lighting appropriate, and hopefully the care team is aware of that. And then transitions to different areas of living, to either assisted living or memory care. And this is often quoted to be occurring when there are uncontrolled behaviors, or incontinence is one of the leading causes of transitions to a higher level of care, because that's just very hard for caregivers to do in the home. And then this is a time for me to just say more about the transitions. This is very individualized based on the amount of family support that is available, resources, both time and money, and the goals of that individual's care. So it's important to talk about that ahead of time. And while some people will come to you, like I know my father has said, I am not going to a nursing home, but some of his ideas of what a nursing home might be may have changed over time, and so just trying to keep that in mind, that it might not be as scary of a place as they might think. But anyway, it's a very, I could talk all for a whole hour about this, but it's okay to live independently as long as safely possible, but that often requires more and more help from others. Try to partner together and go check out different facilities if possible regarding the move, and make sure to ask the facilities about what support they have and the costs for additional services as they are added on. And then us as physicians actually don't have a lot of pull in these transitions of care, which is good and bad. A lot of times I'll have family members come to me thinking I can do something magical by making their loved one transition to another level of care, but I really can't. It's hardest on you as the care providers to make that push and that change. I can suggest it, but I can't forcefully pick them up and move them there. And I can't write an order and make someone go there. It doesn't happen that way. But in really, really challenging cases, or if the person with dementia doesn't have any support at all, we will enlist the county and get adult protection services involved to try to help when there's a huge danger to that person's well-being. So I have a few slides here on medical conditions that co-occur in patients that have dementia, and how dementia impacts the conditions and vice versa. In general, a good mantra even for geriatric care is we try to simplify things as much as we can, and we have a little bit more relaxed goals in terms of our care. So from a cardiovascular standpoint, we might have more relaxed blood pressure goals. We don't need to get that blood pressure perfectly at like 140/90 or below. We can let it float up a little bit. Same thing with diabetes. The blood sugars don't have to be perfect. We can let them ride a little higher, especially if a person has multiple medications and insulin, if they're still living by themselves and having to manage that on their own. We'd rather have blood sugars be a little higher than too low, which would be more dangerous for that person. Bowel and bladder issues. Incontinence can contribute to bladder and skin infections. So incontinence is the inability to control the bowel and the bladder. And some urinary incontinence medications out there actually do contribute to some confusion. So that's important to know and have that discussion with the person's healthcare provider. Mirabegron is a newer medication for urinary incontinence. It's probably the best tolerated from a cognitive standpoint, but it is also more costly. From a blood standpoint or hematology, there has to be a discussion on bleed versus clot risk. So there are some folks who are on blood thinners, but if they're having frequent falls, you might have to have a discussion about removing the blood thinner. And then in general for preventative health care screening as the disease progresses, it's no longer recommended to do like screening procedures like colonoscopies and mammograms, et cetera, because there won't be any long-term health care benefits from those. In regards to hearing and vision loss, which does change as we age, but this is also complicating the dementia process because it can contribute to hallucinations, isolation, and more of the sundowning. Try to redirect those folks as able. In advanced dementia, trying to have a new thing like hearing aids probably won't work very well because they're not used to using them, and it'll just be another trouble and a big investment that probably won't help too much. Decreased taste and smell. This is important because then there's a decreased appetite, which then leads to weight loss. So sometimes we as care partners have to add salt and sugar to make food more appetizing. For allergy symptoms, antihistamines can be has a side effect of confusion. Fexofenadine, which is name brand Allegra, seems to have the least cognitive side effects if you need to. Benadryl is not very good on the brain. And then alcohol, as I mentioned before, trying to cut back if possible. Depression and anxiety. Some of these folks have had history of depression and anxiety for years. It's important to keep that in mind if there are changes in their personality. Don't always just blame it on the dementia process itself. Try to really engage what their mood is. Make sure it is addressed. There's a class of medications known as benzodiazepines for anxiety, and these are oftentimes very we look down upon them in dementia care and geriatrics because of increased confusion and fall risk. So we try to avoid those, as well as a medication called Paxil is just harder on older adults to take. In regards to sleep issues, trying to keep a stable sleep-wake cycle is really important. It can be very challenging, but to try to do the best you can. And then again, avoiding the antihistamines such as diphenhydramine, which is in a lot of like the Tylenol PM, Advil PM. That PM part is the diphenhydramine, which is Benadryl, and that can be has a real big hangover effect into the next day. And then Z drugs, the most common is like Zolpidem, which is Ambien. So try to avoid that. And there are a few other safer options. There's a medication called trazodone that can be used, melatonin, and then one called mirtazapine that I use sometimes if we really need to control sleep. And then pain control can be very challenging. You might have someone who's had a long-term pain disorder on lots of pain medications, and those medications can have side effects on the cognition and vice versa. In late stages, the caregiver needs to rely on some nonverbal cues as the patients aren't able to accurately report their pain level, so watching for things like furrowed brow or moaning is very important. And then going into research. So what's being looked at right now, of course there's more awareness and urgency. For years past, there was this kind of thought that becoming quote unquote senile was kind of a normal part of aging, but it is not. So we really need to work at how do we treat folks who have a diagnosis of dementia. The current medications are really more what we call palliative. They don't alter the course of the disease process itself. They're just simply tools that we use if we need to try to help with certain behaviors and things. Hopefully that we'll be able to in the future identify patients sooner in the course of their disease so that we can truly make a difference. They're looking at things in those mild cognitive impairment patients, such as their language. They've been able to look back at people who have mild cognitive impairment that progressed to dementia and look back if they were like an author and look at their writing and how at some point the style of their writing changed. And so looking for things like that to try to catch things sooner, to start medication sooner and actually make an impact on the overall course of the disease. And currently there's a lot of therapies that are in early stage studies that seem to do okay, but then unfortunately once they get to the large scale trials, they're not working as well as we had hoped they would work. So as I mentioned, the new studies are going to look at drugs that actually try to modify the disease process itself by impacting one or more of the many wide-ranging brain changes that occur in Alzheimer's disease. And it's possible that as we find a cure, that there will be a number of medications that are used, kind of like a cocktail of medications, kind of like someone who is undergoing cancer chemotherapy or AIDS treatment, where there's more than one medication together to treat. And then that's really all just about the biggest subtype of dementia, the Alzheimer's subtype, but that's still not even addressing much of the Parkinson's associated, or the Lewy body, or someone who's had a stroke, etc. So there's a lot of challenges that still lie ahead. So if someone comes and asks about genetic screening, what do I say? Well, Alzheimer's disease is sporadic in approximately 75% of cases. In families that do have a strong family history of dementia, this may be related to genetics, but also environmental factors or a combination of both. And if someone is really insistent on being screened for some of the genes that are implicated in dementia, which I'll talk about in just a moment, we refer to a genetic counselor to really talk with them about what's involved in that, because unfortunately with no treatment, that's a big conundrum. If you find out you're at high risk for dementia, what do you do with that information if you don't have anything to really change the course of the disease? Of course, we always, for no matter who you are, recommend physical and mental health and staying as active and healthy as you as possibly can, but that's not unique to dementia. It's for everyone. So there are two different types of genes. There are the risk genes and the deterministic genes. So risk genes in general just have an increased likelihood of developing a disease. So this may be a factor in up to 25% of cases of Alzheimer's, and it's this ApoE4 gene. The deterministic genes, they directly cause the disease, and this is extremely rare. There's three main genes here, the APP and the presenilin 1 and 2 genes, and this is where multiple family members and multiple generations are affected, and very, very early, in their even as young as 30s. And so this accounts for less than 5% of the cases and is only found in a few hundred extended families worldwide. So some take-home points today. There's a multifaceted approach in dementia care. It is very complex between the patient, their care partners, the medical team. Unfortunately, no disease-modifying medications are available, but it's important to consider them because they may potentially help with some symptoms. Mental and physical activity is wonderful for the brain, so to encourage that as much as possible. Environment is so important, and redirection is a powerful tool, and there are resources available to help. So here are my references. Thank you. What questions can I answer? Okay. We're just looking for some abbreviation. I can come point them out to you if you find it. Yes?
I do have a question. My mother is in the middle to late stages. She's had depression and anxiety for many years. And we're just finding out of her kidneys. She's having weak kidneys.
Okay.
And with going on and off depression meds back earlier, and just probably being not in the right state of mind,
Mm-hmm.
it's floating around and not good thinking.
Mm-hmm.
And I believe she's on Namenda.
Okay.
Namenda, number one, first question is that really mean, like, you can't go off of it, ever?
Okay. So,
And then,
yep.
and then the other question quickly is, what would you recommend, because I know she's doing some blood work for that kidney issue, and what would you recommend on that one?
Yeah. good question. Good question. So I have a question here about your mother that has middle to late stage disease and has some kidney problems as well, and questions on the medication amantine or Namenda, and just any other tips that I can give. So yes, you could have her come off of the amantine. All these medications, they can be stopped at any time. Just be aware that you might see a little change. It's usually very small that you notice something that's different when you go off of the medication. So if need be, if you think it's not helping anymore, the physician doesn't think it's really doing anything beneficial, depending on her stage of kidney disease, the dose of memantine has to be cut in half. So they should be aware of that. And so that's kind of the one thing. She could go off of it or cut it in half to transition off would be okay. And then other questions regarding the kidney disease in general. Hopefully, depending on what level of kidney disease, because there's like 5 main stages of kidney disease, and it's very alarming sometimes when patients get their like list of all their diagnosis and it says chronic kidney disease, stage 1, 2, 3, or whatever. So talking with the healthcare provider about really how severe is this, because a lot of people will hang out in like stage 3 kidney disease for the rest of their life, and it really won't ever become a problem. But if it's really kind of bordering on like moving towards dialysis range or something that's quite advanced, then a lot of medications probably have to be adjusted. And so but there's nothing specific. I mean, for kidneys, we a lot of times try to keep them, these organs are very sensitive, try to keep them very happy and kind of in a normal range. So not too much fluid, not too little fluid, avoiding dehydration, avoiding the anti-inflammatory medications, so which are called like NSAIDs. So the ibuprofen, Aleve, aspirin type products are hard on the kidneys. And then mood. You had a question about mood as well, correct?
I didn't, but we just know that that's been, her mood has been uncomfortable and hard for the last 20 years.
Yeah, so that's hard. Trying to get these folks are hard to find, but geriatric psychiatrists are very helpful. And so asking her primary care provider about if there are anyone in that area that really focuses on geriatric psychiatry can be really, really helpful. Yeah.
Hi, I just have a quick question. It's not really a question, it's more of a statement. Namenda, Aricept, why are these medications on tier 2, sometimes tier 3 with insurances? And when we hit the caregiver wall dealing with our family members' insurances, and how do we try to change that so that they're tier 1 and are included and you get a better rate?
Good question about the tier of medications. I wish I had a good answer for you. I don't. I mean, it's very complicated, and as far as any medication, sometimes the new calendar year comes up and the formulary changes and that changes. So donepezil is probably the cheapest one of that first class that I mentioned. So trying to use that one if possible, and then
adding Namenda, though, that's tier 1, tier 3, or tier 2, tier 3.
This came up on a patient recently for me is check if the insurance needs what's called a prior authorization, because sometimes that might help. Also, the extended release memantine is oftentimes more expensive than the shorter acting. So if you can get away with the twice daily formulation, that'll be cheaper, which is just as effective. There's really no reason that someone has
that is still tier 2.
It's still tier 2, yeah. I'm sorry.
I'm just wondering, the cause of death, what's put on the death certificate usually? Is it dementia or is it usually something else?
Good question. It can be dementia. That's oftentimes seen or related to. So oftentimes, if as a disease process goes on and there's no other major health problems other than dementia, those folks will die from something like a pneumonia or an infected pressure ulcer or just lack of nutrition and unable to eat anymore. But that's all related to the underlying dementia process, really, and the lack of the ability to complete those ADLs and take care of themselves.
One class of medications you didn't address was neuroleptics, and I was wondering what comments you have about when not.
Yes, good question. Yes, so neuroleptic medications. So these are the type of medications that sometimes I don't use them a lot, but they can be used if there are like what we call behaviors. And again, like we know there's that kind of can be a negative connotation with that term, but so they can be powerful. This is where like a geriatric psychiatrist can be helpful, but they can help with calming people down if they're very agitated or help with sleep. A common one is quetiapine or Seroquel, but there's a whole group like that. Risperdal is another group of medications. So, but I try to use that redirection if possible and changing the environment as much as possible because those medications can have negative side effects like for cardiovascular risk, stroke risk. An important note though, if the type of behaviors are really so severe that the quality of life is so poor, you can have a conversation with the patient and their caregiver about, is it better to try a medication to make them comfortable, calm them down, not be so agitated if you've tried everything else, you've tried the redirection, the reorientation, everything, and you just really need something to calm things down a little bit. It's probably better to take that risk, try that medication, because the risk of stroke is there, but it's low enough that you'd rather, for a quality of life perspective, use those medications.
Okay, I have a question for that drug. I was just recently prescribed that drug for bladder care. And so it's a low dosage, but it's also fitting right into what your conversation is about.
Is that the mirabegron?
I didn't hear the question.
The mirabegron, is that the drug that was for bladder control?
For the 5 milligrams. Lisinopril?
Oh, lisinopril?
Yes.
Oh, lisinopril is a good drug.
No, I understand.
Yeah.
It's working good for me.
Okay.
But you're saying watch out for it.
I think I might need the question repeated. Oh, you're okay? Okay.
Do you what can you talk about in terms of using cannabidiol and maybe its interaction with other drugs?
Oh, so
CBD?
yeah, I haven't used it at all, so I don't have a lot to really say. I haven't used it at all, so I don't know too much about it.
I was going to ask about medical marijuana.
Oh, yeah. Yeah, yep, And like, yeah, so in regards to like medical marijuana, so each state kind of has their own legislature about medical marijuana, and Minnesota has their own, and the last I saw that dementia wouldn't be an approved diagnosis to get that covered.
I have a question about the care setting in a hospital. So my father has mild to moderate Alzheimer's. He had 2 heart attacks, and so he was in the hospital twice, each time about 5 or 6 days. We had a really hard time getting the care providers, first of all, to even read the chart, and then to recognize the diagnosis of Alzheimer's. So nurses, doctors, physical therapists, occupational therapists, they all would come into the room having no recognition of the fact that he had Alzheimer's. They would say to him, "So, how are you doing today?" And he'd say, "I'm great." And they'd go, "Okay, bye."
Yeah.
So, do you have any suggestions for dealing with that? I mean, we got so frustrated.
Oh, I'm sure.
Yeah.
Yeah, I'm sorry. Yeah, good question. Yeah, that's too bad. I'm sorry that happened to you and your family. But just trying to bring it up as much as you can and give examples, I guess, to the care team saying, you know, my dad has Alzheimer's, he needs help with this, this, and this, please cue him. If they let you stay with him while he's there, that can be helpful. But you're right, it is a problem. It's so fast-paced. There's so many providers going in and out of rooms. It's terribly confusing to patients with dementia. We realize that. But as much as you can speak up for him, the best. And I know that there's a doctor, Dr. Martha Nance does a lot of work here with Struthers Parkinson's Clinic, and she started a program like through Methodist for the Parkinson's patients and really promoting this big awareness every time a person goes into the hospital with Parkinson's, where those folks really need their medications at certain times, and it's so important. And so they have a little card that they bring in, and they hand the card out to every nurse and physician and therapist that comes into the room. So you could create something like that maybe, and just say, this is who my dad, this, you know, even personalize the things that he likes to do, things he responds to, nicknames, anything that you can think of would probably be helpful.
I have a question about hospice. At what point would they meet criteria for hospice services?
Good question. So oftentimes they have to have something along with the dementia, such as like an infection to be co-occurring. Hospice in general, no matter what diagnosis, we as the healthcare team has to think that the patient has like 6 months or less to live. That being said, there are a lot of patients that live longer than that on hospice and get recertified time and time again. So it is just an estimate. But yeah, talking with the healthcare team about that it's always appropriate to bring that question up in the individual patient case.
Can you tell me the difference between Namzaric and donepezil and how much better Namzaric is?
Good question. So the difference between Namzaric and donepezil, so the Namzaric has 10 milligrams of donepezil within it. So that's the same. And then Namzaric also joins the memantine is also in the Namzaric. So it's like a 2-in-1 pill. And so I think I only maybe have 1 or 2 people on Namzaric because cost is the biggest issue with that. It's cheaper to prescribe the donepezil and the memantine separately than to prescribe it with most health plans, I think, that I've seen. I had one patient who has a lot of difficulty with swallowing. So 1 pill a day was kind of all they wanted to do, and that's where the benefit in the Namzaric would be.
I'm not going to try to pronounce the medications, but
okay.
The medications that are used for Alzheimer's, are they effective at all if the mild cognitive impairment that occurs with the Parkinson's diagnosis?
Okay. So a question regarding the medications and mild cognitive impairment and Parkinson's diagnosis. Sometimes they are used, yes. Very good question. It's worth a try, at least. They're not harmful unless they have some of those negative side effects that are unrelated to the disease, like diarrhea or something like that, but it's worth trying.
You mentioned one patient had a difficulty with swallowing, and is there any reason to avoid crushing any of the medications for Alzheimer's or dementia?
Ask the pharmacist. Like capsules can't be crushed. Some certain, and like medications in general, there are certain things, and I don't have them all memorized. I'm sorry, but capsules can be opened up and sprinkled and things like that, and a lot can be crushed. But ask the pharmacist to be sure.
Can you talk about vision and, because I understand, I just talked with Services for the Blind, and it wasn't common knowledge that Alzheimer's had a vision aspect to it, or loss of vision. And then I started reading on it. She passes her vision tests. So she's got glasses, she's got good vision, but something's going on. And how do I get that tested and give help for that?
Yeah, good question. You might visit with like an occupational therapist. They can do some assessment of the cognitive aspect of the visual piece. And I'm not sure if when she had her vision tested at the eye clinic, if they were aware of the cognitive changes or not. But try occupational therapy because yes, there can be an overlap there. Also, patients that have just other eye disorders like macular degeneration or glaucoma that clouds the vision anyway can make it more challenging for patients with cognitive impairment to appreciate their environment. And also there's some interesting syndromes where like a macular degeneration can cause more hallucinations, but it's related to the macular degeneration more so than it's a visual type of a hallucination almost too. So working with the eye doctor and an occupational therapist might be helpful.
Could I ask you a question? I have a mother with significant, she's got significant behaviors with calling out, crying for her mother. I'm lost, I don't know where I am, help me. She's days and nights mixed up. She is on some pretty heavy doses of neuroleptic drugs. And we are staying with her nightly because we're so afraid of her falling, and she's in memory care. She can't have any kind of additional side rails, no recessed mattresses, no mats on the floor, no anything. And I can't live with the fact that she would fall on the floor and hit her head and be confused with this. She's got macular, legally blind. I mean, she's got it all. I just don't know about the restraint thing. If you can address that, and it may not be you, but as these people advance, I mean, restraints, and I get it, some people have died because of restraints, but how many people have had other problems related to falls because there wasn't something there? It's frustrating as family, and we're really trying to figure out what's next because we can't keep staying with her.
Right.
That 24 hours a day. So, okay, that's it.
Yeah, no, good question. It is challenging. I can't give you like one exact easy answer to that. I think if she's trying to get up, to get around, trying to, if the best you can, figure out what she's trying to achieve. If she's hungry, if she's sore, if she wants to move, and trying to help her with that. It sounds like there's a lot of layers to that, and so she just might need to have someone with her 24/7, which I know is hard to do. To try to minimize the risk of falls or more and more medications. Sometimes working with the healthcare team to scale back on medications actually might be helpful, but it has to be done very carefully and carefully monitored in that regard. So, and I don't think I've had a question really about restraints in the home care setting yet. And in the hospital, they try very, very hard not to use restraints unless the patient is at significant risk of hurting themselves by pulling IVs out and things like that.
One of the things that I just want to say, kind of piggybacking on a few questions that have come up. I've been a care partner for many years, and so failed at some things and then things succeeded, and that is a lot of what it is, especially because all individuals are different, so it's a little bit different journey for everyone. But one of the best things that I see has worked for me and families is to get a journal. And journal, and even if you switch on care partners, where there's different shifts, because the person themselves, and even sometimes people that are very close to them, it's overwhelming. Like that one woman said, it's very overwhelming. Right now my mother's in it, but I have cared for people up until they've died. And also I've just been into it and studied it. And right now I have 7 siblings. So last year my dad died of cancer. And then 7 siblings who were all in different places of understanding dementia. Really, they had no education. And I had to step back and realize you can't just give them a report. That'd be overwhelming. And so it has to be baby steps. But that was very hard for me because of the things they did to my mom, which I would have done a much slower pace. But what's very helpful and what I've seen with other people is that I've counseled, I'll say, well, what are you on, Mary? And this is other people that I've cared for. And they'll go, well, I'm taking this, and then her husband speaks up and I go, okay, now, why are you on that? What did your doctor say? What's going on? Well, I don't know. Okay, well, how long have you been on it? Oh, she's been on it years. Okay, and you're not sure what it's for. Well, and that's even for me when I go to the doctor, but I do take notes and I ask a lot of questions. But in regards to the woman who has her dad in the hospital, what we have to do as care partners is really be the voice and the heart and the advocate for anyone we know, whether it's someone in the hospital. Make something and put it on the door. They're not going to say no. Whatever your intuitive feeling is for someone you love, do it. I mean, you can ask, but no one's going to really say no. It's just that we don't know, and that idea doesn't come up until sometimes in a support group or at something like this. What's wonderful about when you can advocate for someone, they feel safer. They know that someone's got their back. When you can go to a doctor's appointment, what helps the doctors is when that doctor puts you on a medication, that medication has, and I know because I'm very sensitive, can't be on really drugs, that medication has a 50-50 chance, maybe less of working, even more of messing up your normal system. So what helps is take notes. And take notes on when that loved person acted up or did something unusual, because it could be the medication and that's what the doctor needs to know. But you have to kind of track it and then also see what else happened that day that could have bothered that person. For instance, it could have been that person wanted to go to Perkins, but your brother didn't want to take her there. He took her somewhere else. But like the doctors have said, that could upset them. One more thing. In regards to the situation of the woman who needs care 24/7, again, that's your mom. Go ahead and advocate. Do what your heart says and believes in, because then we're going to be happier and more at peace ourselves that we know we spoke up and gave the best care that we know who we're caring for deserved. So.
Thanks.
My wife has been on Exelon and more recently galantamine and then Amanda for 6 years. Does there come to be a point where it doesn't make any sense to continue with those medications?
Good question. It's such, so it's an individualized thing. If you can see a definite improvement or change of some sort, it doesn't have to be big, but if starting a medication does something helpful, then it's reasonable to continue until, and again, this is kind of vague, until there's no other help being provided by that, or if this is working more with the whole care team about if the disease process is advanced so much that their full care in terms of all of their day-to-day measures, then it's reasonable to at least talk about pulling back the medication, because you may or may not see a decline when you stop that. So, but in general, the studies would show that that class of medication that you mentioned, that first class, is helpful for up to about a year. They'll show that in the study. Now, that being said, a lot of patients are on them much longer than that. And it's just because maybe there's no side effects, and we still need to know more information. That's the thing. We're still doing research and trying to figure things out. So keeping them on unless there's a side effect, but it may not be, especially as those other drugs get more, the Exelon and the patch and stuff can be really expensive, so it might not be worth that extra cost. It's not going to give a lot of extra benefit, unfortunately.
Everyone join me in thanking Dr. You did a great job.
Thank you.
Wonderful job.
I didn't use my notes.
Yeah, you did. That's a lot of notes, so thank you. Thank you so very much. Sorry about that. Hopefully, I think you can still hear me anyway. So again, fill out your forms, in terms of the registry forms, the remote activity monitoring study, the eNeighbor project, if you're interested in being part of that. See Quinn Maroney regarding the facial recognition technology study in the exhibit hall. One quick thing, too. The School of Nursing's communications office, they wanted to do some videos with families who have attended the conference here. Obviously, you here today. Tom Steffes is right back here. Can you raise your hand, Tom? Big, tall guy there. And he and a videographer will be there if you'd like to share your stories, both really briefly about your stories and then also about the conference itself. Now, you're free to trash the conference and me, too. It just isn't going to get on the webpage, but I mean, you can do that if you want, I guess. So you're free to do that, too. And so with that, I think we'll break for lunch. Is Sharon Lucilla here, by the way? Can you raise your hand, Sharon, if you're here? Okay, good, Sharon. Your gluten-free lunch is at the end of the table, so just go up and grab it. So, yeah. I want to remember. So, no, please don't steal the gluten-free lunch at the end of the table. So we'll be back at 12:45. There's lots of places to eat, and thanks again, everybody.